Hi, my name is Samantha Dragosinovis, and this is my presentation for Case 4. So the first case study that I decided to do was Case 2, a little background of it. So a 4-day-old infant, patient A, is being followed in your clinic. Her birth weight was 5.9 pounds, and the pregnancy and birth, which is vaginal, were normal. Results from newborn screening demonstrated a phenylalanine PHE level of 6.6 milligrams over DL. However, the normal range is 1 to 2 milligrams over DL. A presumptive diagnosis of phenylketonuria was made, and additional samples were obtained for further analysis. Parents deny any family history of PKU. So I decided to first go over PKU. So basically PKU is a genetic disorder. It's an autosomal recessive. So what that means is that's going to be present in both parents, and it is required for both parents to have the recessive gene for the mutation to occur. So it's a decreased metabolism of phenylalanine hydroxylase. So basically a mutation of the PAH gene. It's one of the most important disorders of amino acid metabolism, and it's also one of the most common disorders as well. Per Soumali's article, it's also not good when it's left untreated, especially in infants and children, because they develop a range of impairments, including behavioral, mental, neurological, and physical symptoms. So what does PKU affect? PKU affects tyrosine. So tyrosine basically becomes an essential amino acid because of the lack of phenylalanine. Basically, phenylalanine uses PAH to make tyrosine. And without PAH, we can't make it. So why do we even need tyrosine? Well, it helps with hormone functions such as adrenal, pituitary, and thyroid, and the production of melanin. And it's also essential for the production of neurotransmitters. So for like flight or flight. Transmitters like epinephrine, norepinephrine, and dopamine. So phenylalanine and tyrosine are very much engaged, and tyrosine is generated from phenylalanine by hydroxylations of the phenylalanine benzene ring. Tyrosine is here on the left, and then this is phenylalanine on the right. So phenylalanine catalyzes tyrosine. So basically it takes the hydroxyl group. And why is phenylalanine accumulating such a bad thing? Well, it could have severe issues with the brain. So it could have severe issues with the brain because with phenylalanine levels accumulating in the body, it damages the central nervous system, and it becomes the brain damage pretty much becomes toxic. Here's an overview of what the regular phenylalanine metabolism is like. So see phenylalanine, PAH hydroxylase, and then goes to tyrosine. Well, on the right is how PHE is affected. So it's not. So per the case study, they also tried a PHE dietary restriction therapy for patient A. It was initiated at 14 days of age with a good response of plasma PHE levels that dropped within normal range, which were 1.65 milligrams per DL. And another infant, patient B, was also being evaluated with suspected PKU. So what they did was they tried BH4 loading tests on both patients. So what is a BH4 loading test? Per the case study, it's a tablet of synthetic cofactor that's dissolved in 20 milliliters of water and dim light and administered to the patients at least 30 minutes before a meal. Blood was drawn before and 4 to 8 hours after BH4 loading. The pH levels were. So pretty much the patient A's PHE levels went up. So they had more PHE levels after BH4 loading, and patient B's PHE levels went down after BH4 loading. So what BH4 loading does, BH4 basically acts as a cofactor in the conversion of PHE to tyrosine through the catalytic activity of PAH and the production of neurotransmitters. It serves as a catalyst for nitric oxide synthase during the synthesis of the messenger molecule nitric oxide from the amino acid arginine. Inefficient biosynthesis and or regeneration of this critical cofactor may lead to development of PKU, hereditary progressive dystonia with marked diurnal fluctuation, or neurovascular dysfunction. So with that, all of that being said, it seems like patient A had a had a better outcome with the dietary restrictions and most definitely has PKU. The thing with the dietary restrictions is that it is lifelong. It's not something that is cured. They just have to follow the dietary restrictions on that in lowering levels of PHE. Patient B most likely does not have PKU. They might have had suspicions, but with the BH4 loading test and observing that them going down, the PHE levels going down, they most likely do not have PKU. Moving on to case 1. So background of case 1. A newborn girl appeared normal at birth, but within 24 hours she developed lethargy, hypothermia, and apnea. The attending physician suspects a metabolic disorder and orders a panel of labs. Which diagnostic would be the best to distinguish between a urea cycle disorder and a disorder in beta oxidation? So urea cycle defects are pretty much a result of relative deficiencies in enzymes that are required for protein degradation. With the urea cycle disorders, nitrogen accumulates, which makes blood ammonia levels rise, and ammonia is highly toxic. So not only is the blood ammonia levels high, which is pretty much hyperammonemia, but the arginine levels also elevate plasma, and the glutamine levels also rise whenever ammonia levels rise as well. And for beta oxidation, any transport defect of fatty acid or an enzyme that's involved in the fatty acid oxidation can cause a disorder. They usually have features of hypoglycemia without ketosis and decreased carbohydrate intake. So let's look at the choices. So we had blood glucose as one of the choices. So with blood glucose, you reduce the blood glucose concentration, and in turn, glucagon signals effort increase in cyclic AMP contractions. So it could have beta oxidation as an indicator, but it doesn't really have an effect on the urea cycle, so it wouldn't be a good indicator on testing. It wouldn't really do much. Urinary acids, they have fluctuating levels, so there's not really a good reason why that would be an indicator. It would just be confusing. It wouldn't be clear. Serum fatty acids, well, they're part of the plasma and cystosol, but they don't determine between urea cycle disorder and beta oxidation. Plasma glutamine, as discussed at the beginning, it kind of fits all the boxes. So it's non-toxic. So it would be, if the levels are elevated, you'd be able to tell. It's a non-essential amino acid. It's not something that you get from your food. It's something that, it's from the body. In urea cycle disorder, plasma glutamine, during the disorder, ammonia will rise, as well as glutamine. So if both of those rise, then you will be able to tell if someone has a disorder, a urea cycle disorder. And here's an overview of the urea cycle to kind of get an idea of where glutamine will occur. So for this patient, a full blood workup was ordered. Their initial blood ammonia level was elevated at 314 UG/dL, but the normal range is 70 to 80. So that was very high. And then it rose to 600 UG/dL. And the urine orotic acid level was marked elevated at 473 UMol/L creatine, and the normal amount is 0 to 3. The plasma citrulline level was normal at 10 UM/L. So pretty much the orotic acid levels are elevated. What does this mean? Well, that's a textbook version of, or that's, the diagnosis would be ornithine transcarbamylase, or OTC, which is an X-linked recessive mutation. Boys are often affected more than girls because of this. And there's very high levels of ammonia and apnea, which is all that the patient came in with. So that would be a deficiency. CPS1 would be impaired, so carbamyl phosphate synthase would be impaired. It'll accumulate in the mitochondria and it'll leak into pyrimidine synthesis, as well as having elevated orotic acid levels, which is what came back from the patient's blood levels. Here are my references, and thank you.